Welcome to Optimal Anesthesia. Today, we explore the challenges of intubating and Ryle's tube insertion in patients with a history of cleft palate repair. These individuals, like our 37-year-old female patient who underwent cleft palate surgery at 2.5 years and is now undergoing laparoscopic cholecystectomy, face unique anatomical variations and scarring from previous surgeries.
Patients with a history of cleft palate repair often have a high-arched palate and posterior crowding of teeth, making it difficult to visualize the vocal cords using standard laryngoscopes. To overcome this challenge, anesthesiologists may use videolaryngoscopes for a clearer view of the airway. Scarring from cleft palate repair surgery alters tissue elasticity, further complicating intubation.
Now we'll discuss how scarring from previous surgeries can pose significant challenges during laryngoscopy and tube placement. Scarring alters tissue flexibility, making it challenging to manipulate the laryngoscope blade for visualizing the vocal cords. This lack of flexibility can also limit the range of motion of the laryngoscope, complicating navigation around anatomical structures. Additionally, scarring can distort the normal anatomy of the oral cavity and pharynx, making it difficult to identify landmarks used as reference points during laryngoscopy. This further complicates the visualization of the vocal cords. The presence of scar tissue increases the risk of trauma during laryngoscopy, as scar tissue is more prone to injury. Excessive force can lead to complications such as bleeding, swelling, and further scarring, making visualizing the vocal cords even more challenging. Scar tissue can also impair tissue mobility, restricting the ability to achieve optimal laryngoscope positioning. This can result in a suboptimal view of the vocal cords and increase the risk of airway complications during intubation. Furthermore, scar tissue can make tube placement difficult, especially if located near the opening of the larynx. This can prolong the intubation process and increase the risk of complications. In addition to these challenges, inserting a Ryle's tube through the nasal route should be avoided in these patients. The nasal route poses a risk of damaging the repaired palate or causing a fistula due to the presence of scar tissue and altered anatomy. Using the oral route for Ryle's tube insertion is generally safer.
Intubating patients with a history of cleft palate repair requires a thorough understanding of their anatomy and surgical history. Anesthesiologists must use specialized equipment and techniques to ensure safe and effective airway management. This report is made possible by the inspiration from Jaya Madam and Dr. Anju. Join us next time for more insights into the world of perioperative care. Thank you for listening to Optimal Anesthesia.